All right, we're going to continue our blood lecture, chapter 18, with hemostasis. And as we talked about at the end of class last week, the first stage is vascular spasm, which is shown here. The second stage is platelet plug formation. And then finally we have the third stage, which is the coagulation phase. So vascular spasm is what happens when our blood vessels constrict. This is the first stage that happens in response to blood vessel injury because we don't want to lose all our blood. So this limits that leakage. And this can last from a few to many minutes, and how long this lasts depends on the chemicals that are released by platelets and endothelial cells, because they are going to stimulate further constriction. And so generally you have greater vasoconstriction associated with greater vessel damage. The second stage is the platelet plug formation. Normally, when we're not injured, do you think platelets are normally going to cause coagulation? Do you want your blood clotting all the time if you're not injured, just in your vessels? No, right? So normally our platelets are not activated. And so this is because the inside of the vessel walls, the endothelial layer, and we'll talk about the different layers of the blood vessels at chapter 20. So normally they are smooth and they're coated with something called prostacyclin. And this prostacyclin is an eicosanoid. Remember, that's one of those locally acting hormones we talked about in chapter 17 that actually repels the platelets. So it stops them from sticking to the inside of the walls. And it causes those endothelial cells and the platelets to make cyclic AMP, and that inhibits the platelet activation. But when blood vessel is damaged, a platelet plug is then formed. So the blood vessel is damaged, that's going to break up the endothelial cells, right? And so the endothelial cells are going to be disrupted on the inside of that vessel wall. Collagen fibers in the vessel wall are exposed. And then the platelets can then, since they don't have that, it's not smooth anymore, and the endothelial cells that are coated with that prostacyclin are damaged and disrupted, the platelets can stick to that. They stick to the collagen with the help of something called von Willebrand's factor. So when the platelets stick, they develop these long processes that allow for better adhesion. And many of the platelets are going to aggregate and close off the injury. And so that's kind of the plug that's forming, it's closing off the injury. The platelets then can become activated. And so when they become activated, the cytosol is going to degranulate and release chemicals. So they have little granules inside their cytosol, and then they're going to release those out to release chemicals. And these chemicals do a couple of important things. And so first of them, the serotonin and thromboxane A2 cause prolonged vascular spasms. So as we talked about in that first step, the vascular spasm, it can be longer or shorter depending on how many of these chemicals are released. ADP and thromboxane A2 also attract other platelets and facilitate their degranulation. So this is a positive feedback mechanism. Some platelets get stuck and they degranulate, and that causes other platelets to get stuck and also degranulate, and that's going to keep going, positive feedback, until the blood clotting is done, right? Until we stop losing blood. And so there are also procoagulants that stimulate coagulation. We'll talk about coagulation in the next phase. And then there are some mitosis stimulating substances that trigger repair of the blood vessels, right? Because we eventually want our blood vessels to repair. So thrombocytopenia is a word that means low platelet count. So thrombocyte, right, is another name for platelets. And penia is low, so low platelet count. And that actually impairs all phases of hemostasis, because remember, this first part right here, the second step is platelet plug formation, right? So obviously that's impaired if we don't have enough platelets. The first step is vascular spasm, and these platelets are going to sort of feed back and help increase the first step, which is vascular spasm. And then the third step is coagulation, and the platelets also, when they degranulate, they release procoagulants that stimulate coagulation. So platelets are actually important for all three stages. And so the platelet plug usually forms quickly in around a minute, and it's prevented from getting too large because the nearby healthy endothelial cells are going to continue to secrete that prostacyclin, which is going to inhibit them from sticking and activating in the other areas. All right, the third stage is the coagulation phase, and this phase is a little bit more complicated. We'll talk about that in just a moment. But this is really when blood clots. And the first thing that happens is that we have a network of fibrin, which is an insoluble protein that forms a mesh. And we can see in this picture, these are the little fibrin things right here, and then we've got platelets also that are attached to them, and then red blood cells or erythrocytes that are getting caught sort of in this mesh. And so the mesh is going to trap the erythrocytes, the leukocytes, platelets, and plasma proteins to form this clot. And so there are many substances that are involved in coagulation. Clotting requires calcium, it requires clotting factors, platelets, as well as vitamin K. So we'll talk a lot about different clotting factors. Most of them are inactive enzymes that have to be activated in order for clotting to happen, because as we said, we don't want like uncontrolled clotting to happen in the body. And they were named in order of their discovery. So factor 1 is fibrinogen, factor 2 is prothrombin, etc. So they are named numerically. Most of them are produced in the liver. So if in the cases where there is severe liver damage, sometimes there can be clotting problems too. Vitamin K is a fat-soluble coenzyme that's required for the synthesis of clotting factors 2, 7, 9, and 10. And so if we don't have that vitamin K, a lot of times you have lower levels of some of those clotting factors. And then some factors, like factor 7, are proteases that cleave other factors, which means they convert them from the inactive to the active forms. So when we initiate the coagulation cascade, clotting is going to start, and it can either start through the intrinsic or the extrinsic pathways, and then these pathways converge to one common pathway. And so we'll talk about the extrinsic pathway first, and it can also be called the tissue factor pathway. And this is initiated by damage outside of the vessel. And the two steps that happen take about 15 seconds. So the damaged tissue is going to release tissue factor, which is also called factor 3. So remember that tissue factor is factor 3, and it's also called tissue thromboplastin. I know they have a lot of names for these. So the damaged tissue releases tissue factor or factor 3. Then tissue factor or factor 3 combines with factor 7 and calcium to form a complex. And so this complex is then going to convert inactive factor 10 to the active factor. So that is the extrinsic pathway. Factor 10, once we get to the active factor 10, is going to be the beginning of the common pathway. So you can remember that the extrinsic pathway uses tissue factor, which is factor 3, plus factor 7 to activate factor 10, right? So 3 plus 7 equals 10. That's a good way to remember the extrinsic pathway. All right, the other way is the intrinsic pathway. And the intrinsic pathway is initiated by platelets upon damage to the inside of the vessel wall. And so these are 5 steps, and they take about 3 to 6 minutes to complete. So as you can tell, usually that extrinsic pathway is going to happen a little bit faster, right? It takes about 15 seconds. So that'll be happening faster, but then our intrinsic pathway is also going to start happening in a couple minutes. And so first, the first step is that platelets adhere to the vessel wall, right? We talked about that already in that platelet plug formation, and they're going to release factor 12. Factor 12 is then going to convert the inactive factor 11 to the active factor 11. Factor 11 then converts the inactive factor 9 to the active factor 9. Factor 9 binds with calcium and platelet factor 3 to form a complex. And that's going to convert the inactive factor 8 to the active factor 8. Factor 8 then changes inactive factor 10 to active factor 10. So as you can see, once again, the last part of this is changing inactive factor 10 to active factor 10. So active factor 10 is going to be the start of the common pathway. I know this is a lot of different factor numbers, and they're not all in order. A good way to try to remember the intrinsic factor is the phrase, in Walmart, nothing sells for $12, it always sells for $11.98. So the intrinsic pathway starts with factor 12, then factor 11, then factor 9, then factor 8. And then at the end, obviously, we're going to be going to the common pathway, which starts with factor 10. So the common pathway, as we said, can be activated by either the intrinsic or the extrinsic pathway. And there are 4 steps in there, and it's going to start with that active factor 10. And so factor 10 is going to combine with factors 2 and 5, as well as calcium and platelet factor 3, to form the prothrombin activator. And so prothrombin activator is going to then activate prothrombin and convert that prothrombin to thrombin. Thrombin will then convert soluble fibrinogen to soluble fibrin. And so now we have fibrin. Factor 13 is then activated in the presence of calcium. Factor 13 cross-links fibrin monomers into a fibrin polymer. And then positive feedback is then going to lead to clot formation. Clot formation stops once the fibrin fills in that mesh. And then extra fibrin is destroyed by enzymes in the blood. And so this is just a lot of steps. So I want you guys to go ahead and write out the steps, and there's a good image in your book that we can look at right here. And this is going to go through both the intrinsic and the extrinsic pathways, and then also the common pathway. And remember, we talked about how calcium and platelets are important for all the different portions of this. So calcium comes into play here, 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 and then also we have platelet factor 3 that comes into play here, and then remember we said that's why platelets are important in all of the different stages of blood clotting. And so here that fibrin is going to help form that nice mesh, that nice clot. And then we have the intrinsic pathway is going to be damage to the inside of the vessel, and the extrinsic pathway is damage to the outside of the vessel. That's what sort of causes those. So when we're losing blood, I mean, no matter how fast the clotting factor, the clotting cascade happens, and how fast we try to close up that area, you're always going to lose some blood. Depends, obviously, if it's a bigger wound, you'll lose more. If greater than 10% of blood is lost, then you're going to have a sympathetic response to blood loss, right? And that's kind of going to give you that fight or flight, because obviously there's a problem, right, if you're losing greater than 10% of your blood. The sympathetic nervous system is going to increase vasoconstriction, right? That means the vessels are getting smaller. We're going to increase the heart rate and increase the force of heart contraction. And that's because if we're losing blood, our blood pressure is dropping because we have a smaller volume of blood. So by increasing the heart rate, how fast the heart beats and how strongly it beats, and we'll talk a little bit more about this in the next chapter on the heart, then we can, make sure that our blood pressure stays high enough that we can move blood throughout our body. The blood is redistributed to the heart and the brain because those are the two most important things that we need to keep going if we're, continuing to lose blood. And this is effective in maintaining blood pressure until around 40% of the blood is lost. And hopefully by that time we've had some intervention and we are going to stop losing blood. All right, so we did talk about forming our clots. Clots are very important in stopping blood loss, but we don't want them to stay there all the time. We want to eliminate the clot once the vessel has healed. And so clot elimination includes clot retraction as well as fibrinolysis, right? So that's lysis meaning to break down, and fibrin here, so we're breaking down that fibrin. So I know we took so many steps to build the fibrin before, and now we're going to break it down. So clot retraction happens first. Actinomycin, which is a protein within the platelets, is going to contract and squeeze the serum out of the developing clot, and that's going to make it smaller. And then we have fibrinolysis, which is the degradation of the fibrin strands by something called plasmin. And this begins to occur within about 2 days of the clot formation. By that time, we should have some healing occurring in the endothelial walls. And it occurs slowly over a number of days. The blood is it's very important that the blood balances clot elimination and clot formation, because we don't want to eliminate the clot too quickly, before blood has stopped, before the endothelial wall is fixed, before we've stopped bleeding, but we also don't want to overdo our clot formation. Imbalances in this can lead to either too much bleeding or blood clotting disorders. Damaged vessels, impaired blood flow, arthrosclerosis or vessel inflammation can tip the balance towards clotting, and this can cause the body to create clots when it doesn't need to really create them, and that can be a problem, right? We don't want to have blood clotting that's happening within our vessels if they're not needed, because those blood clots can clog things up. And then certain nutrients, ions, and vitamins must be present for the clot to form properly, as we said, especially calcium, vitamin K, and some of those other things that we need for that clotting cascade must be present, all the clotting factors for that clot to form correctly. All right, so that's pretty much what we're talking about with clotting. The very end of this lecture just goes over a little bit about development and aging of blood. We talked a little bit about blood development, right? The hemopoietic stem cells. They first develop in the embryonic yolk sac, and then they go and colonize the liver and the spleen and the thymus. These cells become hemocytoblasts, and if you remember the hemocytoblasts that we talked about with blood formation, they are going to be those blood stem cells, and mostly we're going to find them in the red bone marrow. So they're going to go and colonize the red bone marrow. And by birth, all the blood is produced here. So when in embryonic development, you've got blood produced in lots of different places, but once we have the area for the red bone marrow to go, the hemocytoblast will go and migrate to that red bone marrow and start producing from there. And then, as we said before, hemopoiesis occurs in most bones in young children, but by the time you get older, it's restricted to selected bones in the axial skeleton. Aging in blood, older red bone marrow is going to be replaced with fat as the individuals age. So as you get older, you're going to have more yellow bone marrow and less red bone marrow. And so older individuals don't have as much of those blood stem cells, right? The hemocytoblast, they don't have as much red blood cells to make the blood, and so they're more likely to become anemic. Many produce fewer and less active leukocytes, right? White blood cells, and so the immune system is a little bit more suppressed. And certain types of leukemia can also be a little bit more prevalent in the elderly. So the last thing we'll briefly mention is that, since we're talking about blood clotting, bleeding and blood clotting disorders. I'm not going to test you on the disorders, but it's good to know a little bit about some of the disorders that are possible. Hemophilias are bleeding disorders. You've probably heard of them. Sometimes they were prevalent in some royal families. Hemophilia A and hemophilia B are the most common, where the males exhibit the full-blown disease and females are typically carriers. And they result from deficiencies in some clotting factors like factor 8, factor 9, or factor 11, which is more rare. Thrombocytopenia, as we said, is platelet deficiency. And so this can be caused by a number of things, either increased breakdown of platelets or decreased production of platelets. And it may occur in either bone marrow infections or cancers. Certain drugs can also interfere with clotting. Aspirin is one of them, especially, that can decrease how much blood clots. So sometimes people who are more likely to create clots will be asked to take low-dose aspirin. It's also important to ask whether your patients are taking any medications. A lot of times they don't consider aspirin a medication, and so make sure to ask, especially if it's before surgery, if they've taken any aspirin in the last little while. But also ibuprofen, warfarin, and ginkgo. So any of those can, if we decrease clotting, you want to know that if you're going to surgery, things like that. And then finally, hypercoagulation is that increased tendency to clot the blood. And this can lead to what we call a thrombus, or a blood vessel clot. And this thrombus forms within the blood vessel. It's usually inappropriate, and it can actually break off. And when that breaks off, it's dislodged, and it starts going within the blood vessels and floating around, and we call it an embolism, or an embolus. And this embolism can lodge in different places, and when it lodges in different places, it can restrict the blood flow to that area. One of the ones that's really dangerous is if it lodges in the lungs. We call that a pulmonary embolism, and that can cause breathing problems and death sometimes, because then the blood can't get to the area in the lungs. And this can have drug-related, environmental, or genetic causes. Like some birth control pills or prolonged inactivity can slightly tip you towards hypercoagulation. Right, so that is all about blood for today.